Galen Healthcare Solutions webcast, Optimization in You. My name is Susie Agostino. I'm a registered nurse and senior clinical consultant. I've been with Galen for about 3.5 years now. My colleague and partner in crime, Ryan Potter, is also a senior consultant with Galen Healthcare Solutions. Ryan has been with Galen for almost 4 years. We have some really great content for you today that we hope will give you a clearer concept of the optimization process. Just a few housekeeping items to get out of the way before we get started. Your phone has been muted. However, we do encourage you to please use the Q&A panel to ask questions during the presentation. We will try and answer a few questions at the end of today's webcast. However, all questions and answers, along with slides from today's presentation, will be posted on the Galen Wiki within a few days. I'm also just getting over a cold, so please forgive in advance if I cough a bit through the presentation or need to take a sip of water. So with that out of the way, let's get started. On our agenda for today, we will go over the definition of optimization. We'll discuss some reasons why we want to go through the optimization process. We'll talk a little bit about PCMH, meaningful use, and healthcare reform. We'll review some of the medical areas involved in the Galen Healthcare optimization process, and we'll also show some analytics tools we use to review and evaluate progress following an optimization. So, what is optimization? Merriam-Webster defines optimization as an act, process, or methodology of making something, such as a design, system, or decision, as fully perfect, functional, or effective as possible. BusinessDictionary.com has optimization defined as finding an alternative with the most cost-effective or highest achievable performance under the given constraints, of course, by maximizing desired factors and minimizing undesired ones. Now, just thinking about either of those definitions, I'm sure you can look at your own organizations and off the top of your head come up with 3, 5, maybe even a dozen areas where something is not working as fully perfect, functional, or effective as possible, whether it be clinical workflow, EHR workflows, or patient flow. A clinical optimization begins with an examination of the entire clinical environment, not just the core EHR. It also includes an in-depth review of the workflows and processes surrounding those systems or areas. So what's next? What do we do next? You got it. Keep calm. Anyway, now I'd like to get into why we want to go through the clinical optimization process. A few reasons include physician or end user dissatisfaction with the EHR as well as with other clinical and or non-clinical processes. In addition to EHR optimization, there are many areas within a clinic or office that can be evaluated, reviewed, and new policies or procedures put into effect to make those areas more efficient for both staff and patients. We'll go over some of those areas shortly. The EHR brings us implementation issues or inefficiencies, lack of support or planning from vendors, inefficient training leading to inefficient workflows. Inefficiencies throughout an organization can be a drain on not only the providers, but support staff and eventually patients as well. When the IT team doesn't understand clinical and vice versa, an EHR build may not meet the needs of the users. End user input is imperative when implementing or when coming back and optimizing your system and your practice. Integration issues. Often with the rush to implement new software, drill-down thorough testing of all aspects of integrating clinical systems is not completed. Suboptimal utilization. The best electronic health record, lab information system, or practice management system in the world is of little value if the users don't use it or use it to the potential, or if their policies and practices are not aligned with the platform. It makes sense to occasionally step back and evaluate how your system was implemented, any updates that have occurred along the way, and if there are opportunities to optimize. The optimization process allows us to understand how the providers use all systems and processes so that we can provide efficiencies to assist them in seeing their patients. And lastly, one other reason, compliance assurance. Regulatory compliance is a big issue within healthcare now. Failing to comply with various industry regulations can result in serious consequences. Excuse me. So what are some of the benefits of optimization? Optimization allows us to uncover solutions to the toughest challenges. This can include thinking outside of the box to develop solutions that no one has yet thought of. With optimization, you want to extract the maximum yield from every resource, whether it be scheduling, staffing, patient initiatives, and identify innovative solutions, and not just cope with, but conquer the toughest conflicts. We want to create measurable return on investment fast. See results within months or even weeks. Now remember, return on investment for us ultimately is optimal patient care. You will see service improve, costs drop, as well as patient satisfaction increase. Patients are happier and so are your employees. In regards to the EHR, we have all heard the complaint from both physicians and support staff, too many clicks. Many organizations realize that after several years of utilizing the EHR, they may not have taken full advantage of the system capabilities. This can be due to staff turnover, lack of user knowledge or transfer of knowledge, or not keeping up with new updates and features. End users will create their own workflows or workarounds, which can sometimes involve many more steps than needed, unintentionally creating a more cumbersome workflow. An example, during an optimization of a large clinic, I watched a nurse go through multiple steps and clicks to find a patient's immunization record, something that you would think would be easily accessible. I asked her why she did it that way, and she explained that that was how they learned to do it, although she didn't understand why the system was built like that since it was so difficult to find. I showed her the correct way to view in about 3 clicks, and she couldn't wait to share that with her colleagues. They were all using an extremely cumbersome workflow to find information due to a non-existent transfer of knowledge. Not only does end users creating workarounds or not using best practice workflows waste time and can be a drain on your staff, it can also cause havoc in other areas of the EHR. One other reason or benefit of optimization, service delivery excellence, also known as optimal patient care. Efficient and productive end users tend to be overall happy, efficient end users and providers, which means happier patients who are much more satisfied with the care they are receiving. Now let's look at a few items that are pushing folks to consider optimizing. Over the past 6 years, with the signing of ARA, or the American Recovery and Reinvestment Act, we have seen a transformation with the delivery of health care. What started as just going from paper to electronic has turned into a total overhaul of how physicians practice medicine and how their clinical and office staff assist them. We now have meaningful use, as I'm sure you are all aware of, and many at this time are attempting to attest for or have just attested for stage 2. Now, I'm sure we all know what MU is, but the actual definition of meaningful use is using certified electronic health record technology to improve quality, safety, efficiency, and reduce health disparities, engaging patients and family, and ultimately improving care coordination, population, and public health. We also see a lot of organizations working to obtain PCMH, or patient-centered medical home, recognition or certification. What is PCMH? You'll see a brief description provided on the slide. However, to further define, a patient-centered medical home allows patients to be involved in their own care, something that didn't happen not too long ago. In addition to the physician, there are many other clinical providers, such as a physical therapist, social workers, nurses, educators, as well as on-site services to provide easier access. A medical home achieves these goals through a high level of accessibility by providing excellent communication among patients, physicians, and staff, and taking full advantage of the latest information technology. Many organizations find that they are able to obtain at least level 1 PCMH certification once going through the optimization process. Some find they are eligible for level 3 recognition. Now on this slide, you will see 13 medical office process areas. Depending on how long your practice has been electronic, and I did make quotation marks with my fingers when I said that, there could be up to 13 areas, sometimes more, involved in the optimization process. This process will include the collecting of data and recording the step-by-step process that occurs for each workflow area, as well as noting the role that completes each step. An area could contain multiple roles depending on the workflow occurring. For example, number 7 in the medical office area is results processing. In a typical scenario, you have the provider verifying the results, and then you may have a nurse calling the patient and or a secretary sending a results letter. The optimization analysis will also involve recording challenges observed and any particular characteristics that pop out. Today we're going to review some of the items that would be observed, assessed, and reviewed for the patient visit. We'll go through appointment scheduling through order management, results processing, medications refills, and triage call processing. For a more in-depth review of the optimization process of all medical areas, please contact sales at galenhealthcare.com. So let's start with the non-clinical workflow process involved in patient flow. Number 1, we have appointment scheduling. At one point in time, the patient called the office and made an appointment or made a follow-up appointment after their scheduled appointment, and that was pretty much it. With the acceptance and use of patient portals, many practices are allowing patients to make their appointments via the portal. Some also allow appointment requests on their website. The appointment scheduling workflow analysis should be conducted with the frontline manager of registration and scheduling, focusing on information collected and or verified at the time of scheduling. When analyzing appointment scheduling, a few items to think through. How are appointments made? How are appointments handled for walk-ins? And for new patients, is a mini registration done, including a temporary MRN? If yes, when does that MRN become permanent? Number 2, we have pre-appointment prep. We need to identify the process that begins prior to the day of the exam in preparation for the appointment. This process may involve pre-registration, medical records chart pulls if the paper charts are still in use, eligibility checking, patient forms, label printing, and so on. To dig a little deeper, how are patient forms provided? By mail, email, on a website? What is the process for missing information? Is the patient contacted? Is the referring provider contacted? Are referrals or consultations processed differently than primary care patients? Number 3, day of appointment pre-exam. Here we should capture the process steps that occur the day of the exam prior to the patient being brought to the exam room. Reviewing check-in process, demographics review, how information is updated if changes, policies for no-shows, late patients, or if a patient leaves prior to being seen by the physician, are all items that we want to review and capture. Now we get into the clinical workflow processes of a patient visit. Number 4, we have intake examination. Here we want to capture the process steps that occur from the time the patient leaves the waiting area to the time they check out of the clinic, including specific forms and or data entry that is completed. Normally, we want to have a nurse or medical assistant who knows office workflow to assist in this evaluation. Some things to take into consideration: is the patient escorted to a room by clinical or office staff? What information is obtained by the clinical staff? Maybe med refills needed, med reconciliation, perhaps the med allergies and problem list. What areas of the patient chart are reviewed prior to the provider visiting with the patient? How are your providers documenting? Read text, voice recognition, text templates, point and click. Who reviews educational material with the patient? Is it the physician, a nurse practitioner, or perhaps a registered nurse? Are charges done electronically, or is a paper encounter form used? Number 5, order management. We need to review the process of managing orders for ancillary services such as laboratory and radiology tests. We need to find out who enters the orders. Is it nursing or the physician? And when are the orders entered? Is it during the appointment or after the appointment? How are in-office labs or testing communicated to the clinical staff? Is it via worklist or tasking within the EHR, or just different colored flags thrown out outside the exam room door? If the labs or radiology orders cannot be performed in your facility, what is the process to schedule them? The next clinical workflow process that we will discuss is number 7, results processing. In this area, we review the process steps that occur once a result is received back from the laboratory or radiology services. We need to remember to distinguish differentiators between any in-house versus outside results. What are some of the other items we look at with results? We want to know who receives the results each day. Does the nurse manager receive them and then distribute to the ordering provider, or is the provider the first to view? Are routine results processed differently than urgent results? And if so, how? Which roles are involved in the verification process? Is the non-lab diagnostic results verification process the same or different from the lab diagnostic results verification process? And if so, how? On to medication refills, number 9. Here we need to observe and capture the process steps for prescription refills from the time the patient contacts the physician, the fulfillment of the refill, and update of the patient's medical record. First off, how are your refill requests received? If you have implemented a patient portal, you may have medication refills set up via the portal for your patients. However, if a portal has not yet been implemented, what other ways do your requests come in? Emails, telephone calls, maybe by website? Is there a refill protocol? This could entail which roles can refill prescriptions, prescription refill turnaround time. For example, some clinics require 48 hours for a prescription to be refilled, in addition to certain prerequisites that need to be met for a prescription to be renewed. Is prospective or retrospective authorization by the provider required? Is there a refill or pharmacy line that patients use only for med refills, or do these calls get lumped in with triage call processing? Now, our last optimization clinical workflow process that we will review is triage call processing. We need to get a detailed description of the process that is used when taking a telephone message for a request received by a patient. We need to include specifics about the prioritization of requests, assignment of the request to individuals, the tracking of requests, and the documentation of the request, as well as the final resolution. Some components of this area to consider: are there specific staff responsible for phone triage? Nurses, medical assistants? Does the front desk answer the call and then transfer? Is voicemail part of the call processing workflow? What are some of the most common reasons for patient calls? Some organizations do create policies or protocols which can be written up to assist staff in effectively handling some of those most common calls. This also helps in regards to some provider workflow as well. How is the call documented? Is there a particular note type used? Is there an on-call process for a physician who is not available? So we've gone over the patient visit, results processing, medications, refills, and triage call processing medical office areas, reviewing information that needs to be analyzed from each area. Once all information has been collected, there needs to be review and collaboration with representatives from all areas, as well as physician champions and/or leadership in EHR steering committees to strategize and come up with a finalized process for your organization. Excuse me. It may be advantageous to have a beta practice or physician who tests out the new processes prior to them being implemented practice-wide. This will help identify any potential issues to assist with change management and end-user acceptance. Once the new workflows, procedures, and protocols are in place organization-wide, remember to establish a continuous quality improvement policy. HealthIT.gov defines CQI, or continuous quality improvement, as a philosophy that encourages all healthcare team members to continually ask, how are we doing? Can we do it better? More specifically, can we be more effective, do it faster, and in a more timely way? Continuous improvement begins with the culture of improvement for the patient, the practice, and the population in general. Now, before we get into our optimization analytics, there is one more item in regards to the optimization process I'd like to discuss. Standardization. Standardization is ensuring standardized processes throughout the clinic or organization. The standardization of processes, forms, or templates used to collect information, in addition to policies and procedures, is critical in order to, 1, optimize efficiency, as well as 2, improve patient safety. In addition to standardizing clinical processes, it is also important to consider standardizing administrative processes. Now, as a former office nurse, I totally understand the desire for many clinicians to have a customized process to meet their special needs, and yes, again, I'm doing the quotations with my fingers. However, every customization can cause operational challenges for the rest of the team and can even lead to medical errors. In regards to office or clinic flow, it can impede the ability of the staff to cross-cover for one another on busy days or if someone is out sick. Whenever possible, use a single process for all clinicians. Now, at this point in time, I'm going to hand things over to Brian for a deep dive into the tools that we use to assess progress of the Galen Healthcare optimization process. So give me just a moment here while I assign him the vendor.
Okay, thanks. Can you see my screen okay?
Yes, I can.
Okay, perfect. So before we dig into the analytics piece, I wanted to go ahead and use one of Sue's earlier slides to kind of briefly highlight a few of the workflows that we will be addressing in the analytics piece. Now, it's important to remember that while these tools are great on their own, pairing them with an on-site workflow assessment is really going to help draft a solid foundation for your organization's optimization effort. By no means is this going to be a complete list of what we can use analytics for. It's just kind of a high-level overview of what everyone can get, so everyone can kind of get an understanding of what is possible. Now, for this example, we will be using data collected from an Allscripts TouchWorks environment, and while there are a few TouchWorks-specific items, we do have a methodology in place to help with other EHR systems. So, what are we going to be covering today? Well, we're going to discuss why we use analytics. We're also going to cover some of the reporting metrics that we used to gather this data. Next, we're going to dive into some real-world examples that will include pre- and post-optimization data. And finally, we're going to wrap up with some quick best practice recommendations. We will not be covering how to build or run the SQL queries that we used in these examples today. So why do we use analytics? There are actually several reasons why an organization may want to look into implementing the use of analytics. The first one being that using analytics is going to help further identify any workflow gaps. While doing an on-site assessment, you are able to visualize the gaps in the workflows. We use analytics to help take that one step further. This is going to allow us to see what specific workflows are working well for an office and where the office could really use some help. It also allows us to compile hard evidence to help affect change. there are times where you may come across a glaring issue, but implementing a solid and clear-cut solution may be met with some pushback. Most of the time, the pushback is because people don't really feel that there's a reason to change. Their current workflow has been, and we'll say, quote-unquote, working for them. With the analytics piece, we can actually approach the physician champions or clinical decision team with hard evidence, showing that there is a problem, and show them why the proposed solution will work for them. And finally, it's going to help create a measurable return on investment. Using pre- and post-optimization analytics can help show how effective the optimization really was and how much time we were actually able to save both the clinical staff and the providers. For the first piece we're going to dive into is tasking. In this slide, you will see some of the metrics we are using to capture a solid foundation of how well tasks are being handled in an office. And the first 4 bullets are pretty straightforward, and those are start and end date, the task name, whether that task is active or inactive, or whether that task is delegated or undelegated. The 5th bullet, count total, is going to give us the total number of a specific task. For example, you'll see in the slide that there were 60,555 sign no tasks generated. In the 6th bullet, we're wanting to see how many specific task types are still active. In this slide, you can see that the RX renew requests are being worked to completion, while the overdue orders tasks have a high active to total ratio, which could be assigned for further investigation of the workflow. In bullet 7, we're looking at the count removed. If the count removed is high, this is usually an indicator that additional training and workflow adjustments are required. Generally, a high removed total occurs when users are clicking the remove button on tasks that autocomplete once the proper workflow has been finished. For example, a side note task auto-completes once the user has signed off on their documentation. If there's a high number of sign note tasks that have been removed, there's probably a large number of notes that require provider sign-off. Count complete shows us the total count of tasks with the completed status by task name for that set time frame. And this metric is typically used as the numerator, while the total count is typically used as the denominator. Average hours to completion shows us the average time it takes for users to complete a specific task. For example, an overdue order here in this report is taking approximately 326 hours, and that's roughly 13.5 days to complete. And the last metric is task owner, and this is typically ran as a secondary report to help break down how well a specific user is at completing a specific task. So what do we do once we have this information? Well, we analyze all of the data collected, and we work with the organization to come up with workflows or system settings that will help the end users. Depending on where the gaps are, we may recommend activating certain tasks to help keep things from passing through the workflow gaps. On the flip side of that, we could also recommend inactivating a certain task because it could actually show up on the user's work list, and it may be easier for them to complete from there. Sometimes we may need to review the workloads that were originally trained. And lastly, we may suggest to delegate a certain task type, depending on who in the office should actually be completing those. A question that we've seen come up multiple times during optimizations has actually been, is node optimization important? And the answer to that question is absolutely. There are several key reasons to consider node optimization as part of the overall optimization process or effort. And one of the most important reasons is it's going to help improve patient care. When documentation is fragmented or hard to read or follow, the person who really suffers in this is actually the patient. Node optimization is also going to help create a streamlined workflow that's easy to follow for all of your providers. We take their everyday workflows and we actually help generate a node that is going to reflect how they practice medicine. It's going to help generate provider buy-in. We work with a team of doctors for each specialty to create a note that is specialty specific. and this allows the providers to actually give their honest feedback on how they want their notes to look and what items to include or exclude from their exams. Working with a team of specialty-specific providers also allows them to discuss how they are currently practicing medicine, and it could help create specialty-specific workflows with patient care in mind. And the last piece is the note optimization. We can actually help assist in getting your documentation ICD-10 ready. And this allows us to ensure that the notes that we build for these providers will meet the new requirements for documenting problems and ensure that the notes won't need to be completely rebuilt once ICD-10 is officially rolled out. So for this example, we're going to use the following metrics. We're going to use date of the patient visit, of the provider that they saw, the document type, the total number of notes created, and lastly, the number of notes finalized or completed by 6 p.m. and by 10 p.m. The document type is an important metric to keep in mind. This is what helps filter between a provider's actual chart note versus a telephone note or a nurse's note and so forth. Now we're going to take a look at some real-life examples. In the first example, we're going to take a look at the task optimization piece, and this includes the number of appointments, average time to completion, and some pre- and post-optimization comparisons. In this slide, we are comparing the total appointment count between October and November of 2013 versus October and November of 2014. In 2013, this office saw 2,361 patients over this 2-month span, and in 2014, they saw 2,558 patients, which is an increase of roughly 197 patients. This next slide shows a snapshot of the average hours to completion for the defined tasks. For example, we can see that the call patient with results averaged 38 hours in 2013 versus 13 hours in 2014. The next two slides are going to show a return on investment report that was put together after a couple of months on the optimized EHR. The first slide that we're looking at, you'll notice that we have 2 columns, one for all months and one excluding the summer months. Since the summer months were typically busier for this office, we wanted to create a fair comparison. If you compare the total times with the summer months, you'll notice that the average time spent on a task per patient went from about 21.5 minutes to just over 8 minutes, and this was a 62% increase in efficiency. If we take out the summer months, we saw that the numbers dropped from almost 17 minutes down to just over 8, and this was still a 53% increase in efficiency. This slide is showing a graph that represents the data from the previous slide, and you'll notice that even though the provider saw almost 200 more patients, the time spent on a task per patient decreased significantly. The next example is going to show how a practice did after a note optimization. For this, we wanted to get an idea of how many notes the providers were able to finish during business hours and how many they actually had to take home and finish. Knowing this, we set the metrics to pull information on notes that were completed by 6 p.m. and notes that were completed by 10 p.m. And again, we're going to look at pre- and post-optimization comparisons. In this first slide, we are comparing November 2013 to November 2014. The patient total for this practice was almost identical between the 2 years. So in the left-hand column, you can see that the average number of notes completed by 6 p.m. in 2013 was 69%. In 2014, we were actually able to help increase that number to 93%, with the smallest margin for improvement among all the providers being 17%. When we look at the notes completed by 10 p.m., we see that the average for the office increased from 81% to 95%, with all of the providers completing at least 90% of their notes for the day. So what was our next challenge? We were actually asked to help optimize a clinic that was already using the system pretty efficiently and provide similar feedback to what you saw in the previous slides. Again, this is going to be a tasking-based example, so we will be using the same metrics as before. And here you'll notice that the appointment count is very similar between the 2 years. In this slide, we took another snapshot to see the average hours to completion for this listed tasks. And again, finally, we produced the ROI report. You'll notice that again that we have all the months listed on the left, and we again excluded the summer months on the right. So even though this office was using the system efficiently, we were still able to shave off almost an entire minute from the time the staff spent on a task per patient. So if a staff member was seeing 30 patients a day, that essentially equates to 30 minutes saved just for one day. Again, this slide is just showing the data that we used from the information above. And finally, we're going to end today's presentation with just a few best practice recommendations. The first recommendation is pretty self-explanatory. If you are running queries against a production database, you want to be sure to do so off hours. If you run queries during hours, you could potentially see a lag in the system, and you could potentially pull incorrect data as patient information may be entered while the query is running. When you start your queries, you want to start simple. You want to make sure that you're collecting the data that is pertinent to your optimization. When implementing changes, make sure to go through the proper channels for approval. And basically, this just means that you want to make sure that you are working with your clinical workflow team and compliance to ensure nothing is going to be slipping through the cracks. You want to ensure someone, and it's typically the clinic manager, is monitoring the work list and task list post-optimization. Excuse me. With optimizations, you're normally introducing workflow variations that need to be tracked. And this is going to allow you to see who may need additional training and prevent them from falling too far behind. And finally, you want to maintain a comprehensive change document that allows you to track all the changes made during the optimization. And normally you want to include what changes were made, what environment the changes were made in, and which analyst was making the change. So this concludes the analytics piece of the presentation. I'm going to go ahead and turn it back over to Sue to wrap things up.
All right, thank you, Brian, for showing us those pretty impressive results from an actual optimization. To conclude for today, optimizing your practice can seem like a monumental endeavor. Although it will take a lot of coordination and cooperation between departments, by using a systematic approach and positively engaging end users, it is more than doable and the benefits are invaluable. If you are interested in engaging Galen to assist you in your optimization journey, please contact us at sales@galenhealthcare.com or go to our website where we do have a Contact Us form. The slides and Q&A from today, as well as other webcasts, can be found on our wiki at wiki.galenhealthcare.com/webcast. And it does look like we have had a couple of questions come in. I think what I'll do is try and organize so that I can take a few, and then I'll let Ryan take a few. So the first question I have is, how long does the optimization process take? That is a fabulous question. It really depends on the size of the practice, and between analysis, observation, and review, coming up with the plan, and then getting it approved. I guess that depends on your clinic hierarchy and if there's any major political stuff going on, as there is in every clinic. Then finally implementing that plan, it could take anywhere from a couple of months to a year. There are a lot of factors that are involved in determining the total length of time that would be needed. The next question is, can optimizing really set up a clinic for PCMH certification, and is this really closely tied with meaningful use? Well, yeah, first off, absolutely, optimizing your clinic can set you up to obtain PCMH recognition. One of the important benefits of EHRs, as well as EHR optimization, is that achieving meaningful use can position you and your organization at the forefront of that ever-changing healthcare landscape. PCMH initiatives, and although it can be tough to go through everything for PCMH initiatives are not only closely aligned with the components of CMS's Meaningful Use Program, there is a lot of considerable overlap between meaningful use and the establishment of a patient-centered medical home. Oh, this one's definitely a Brian question. Brian, how did Galen develop these scripts used to gather the data?
Well, all right. Well, in all honesty, it was a little bit of trial and error. We have a really great team that understands the database sides of all the different applications. So they had some ideas on what data could be pulled from the system, and that was kind of used as a starting point. After that, some folks started thinking kind of outside the box and found a way to break it down to the granular level that we actually went through today. So that's kind of it.
Very cool, and we've got that thinking outside of the box that can come into place in so many parts and areas of the optimization process. Next question for Brian. When you break down the tasking by user, what is the data typically used for? Ooh, and is it ever shared with the user?
Okay, so typically for starters, on the optimization side, that's going to help us get a better understanding of how an office may be doing with their tasking. If there's typically a large gap between users in the same office, that's going to give us kind of a starting point for what users may need a little more help getting comfortable in the system or more training. And as for sharing the data with the users, that's really an organizational decision. Some organizations have used this data to kind of help with employee evaluations, while others have actually, basically they've taken their reports and met with the individuals, or met with their staff individually, and then shared the averages with the team in staffing meetings. So it really just depends on the organization on how they feel can best utilize that information.
Okay, so that could definitely be a very helpful tool, especially if you've got a provider in particular who's having a hard time in keeping on top of whether it be their find note tasks or getting their results verification taken care of. Very cool, very cool.
Definitely. I mean, we've also seen it though on the clinical staff side where sometimes the users will be missing things like meta administration, and it might just be one or two users, but that really helps drive home, you know, how to use the system and why things are entered into the system, and it's to catch those small pieces.
And again, we go back to in the sense when users do create their own workflows or workarounds, how that can potentially cause issues in other areas of the EHR. Specifically, if a med admin isn't entered correctly or if it's not resolved correctly, that can cause issues ultimately down the road for someone else.
Exactly.
All right, well, folks, it looks like that is all the time that we had allotted for questions for today. Again, let me state that any questions that we did not answer during the webcast today will be available on the Galen Wiki within the next few days. We will leave the Q&A panel open for a few more moments to capture any additional questions. And also, if you do have any questions on this presentation, you can always reach us at education@galenhealthcare.com. I would like to thank you all for your time today and wish you all to have a fantastic weekend. Thank you again and take care.